Duty today to share with you about how to use the investigation on the anterior segment of the eye. I think we follow after the glaucoma and retina about 20 years because 20 years ago they have a lot of good investigation, digital, and for the recent year the dry eye and the ocular surface just come up. Every eye doctor around the world just woke up after 2015 or 17 with the these two that come out. So the dry eye is fatigue and sometimes it's a hell. Why? One of my most famous ophthalmologists in the world who discovered the IPL named Rolando Toyot. He mentioned in his lecture one day, if you want to be the best eye surgeon, you have to treat dry eye. And I totally agree with him. Before, I think today most of us do the cataract and refractive surgery. So before the next cataract case, we know that 50% of the pre-op cataract patients have the underdiagnosis ocular surface disease. 75% of the dry eye is evaporative dry eye or caused by the Meibomian Gland dysfunction. And we found that 34% of the post-LASIK or refractive surgery, they have the unhappy case that link to the ocular surface problem if the surgeon did not recognize or did not treat this one properly. So the most common misdiagnosis and undertreatment is ocular surface problem. And why ocular surface is touched in every specialty? I always tell my patient before the eye surgery that we found that every ocular surface or Meibomian gland dysfunction hidden. If we not mention, if we have not treated, approximately every 30% of the case that the ocular surface, intraocular or outside ocular surgery can provoke the case, and sometimes it works for at least 6 months after the surgery. And I love this picture because everyone knows that we was born with the white eyelid margin, no abnormal telangiectasia. Many years later, 60, 70, 40, 50, 60, 70 years, our eyelid going to be on the right hand side. So the question is why we did not stop the progression of the information. So we need the tool to see. So then we need the tool to educate the patient to realize and have the big awareness for the problem. So in my concept, the dry eye or the MGD is an anti-aging. We have to treat them for the rest of their life. The more we treat, the more better. The later we treat, the later damage it. And I'm the oculoplastic surgeon. I'm not the cornea, I'm not the glaucoma. So my focus is inside the eyelid. I do encourage our colleagues to think about inside the eyelid out. Think about the internal core of the eyelid. So when the inflammation happens, the obstruction happens, inside the eyelid can have been distorted and destroyed, and eventually they have the cicatricial entropion. And on the lower right hand side, you can see that in the late stage of the Meibomian Gland dysfunction, the patient have the cicatricial entropion. And this one probably is lost about 90% at least in every case, and the patient does suffer a lot of the dry eye. So thank you for the Topcon that bring the instrument, the equipment, the tool for us to make the patient more understanding. So the next one I'm going to show my experience with the TERA. The new, as you know that last year for the due 3 that they launched about if you're going to diagnose it about the dry eye, they need to have the objective and symptom. If the patient have no symptom, we want to diagnose it as dry eye. But we started with the questionnaire. OSDI-6 questionnaire have been embedded in the machine. If you have time, you can let your technician tick about the score. The score more than 4 is mean the positive. Nowadays, in the old day, we talk about TERA of time for more than 20 years. but that one we need to put some drop. But the Q3 talk about non-invasive tear backup time and use a machine for evaluate about the tear. If the tear backup time less than 10 seconds, we notify that this one got the problem. So when we get the information, we got the diagnosis, we have to clarify if this one caused by the lid problem, aqueous deficiency, or the lipid problem, or the ocular surface primary. So that allows for the treatment. So today we want to talk about the treatment. We will talk about the treatment. We may need 3 hours for the treatment. My all day for the diagnosis about the examination of the dry eye, I use only my good slit lamp. I use a Topcon for maybe 15 years at least, and it's quite pretty good and durable. But to get the very good and sharp picture, you need to be the very, very experienced photographer and really experienced ophthalmologist. But the TERA make the picture easy, that if you finish my talk, you're gonna see how good it is. This is the unit of the TERA. The TERA is a full Placido-based cornea topographer, and they have the ocular surface imager in one unit. With the single workflow examination and integrate the one report for the whole aspect of the ocular surface problem. And in the right-hand side, you can see that this is the images that you use the lens system from the examination room and send the system to the, if you have 10 examination room, you can put the signal and the images to the software in the examination room, and you can see the picture and the image at the same time and can explain to the patient. For the first visit that the patient come, we use about 10 or 12 minutes for the whole test evaluate, but we're gonna get a lot of information I'm gonna show you in the next 15 minutes. So, modern dry eye management requires more than the experience. It requires the right diagnosis too. So, in the device, they divide to be 8 clinical capacity. The first one, most of the old machine, they separated like an 8 machine. But nowadays, the Topcon integrate the 8 machine in one machine. So the first part is the corneal topography, keratoconus screening, non-invasive tear backup time and blinking analysis, tear meniscus height, fluorescein images and video, lipid layer assessment, and Meibomian Gland imaging, and blepharitis assessment and ocular surface brightness. And the Cernicke aberration analysis also in the unit, and pupillometry for contact lens fitting and fluorescein video recorded. This is the unit show when we perform this one. The machine is very easy and very practical. They have the small motor inside, and smart automation is mean just use the tip of the finger to touch in the skin, and the camera will drag and follow the eye and focus to the pupil. So no need to be experienced. We can teach our technician, our nurse, or the doctor, or the young ophthalmologist to take this one really easy. And the learning curve is so short and steep. And by the picture, you can see that the clearness of the picture is so good. And I will show you one by one. The first one, corneal topography. This one is not the whole topography. They check about the anterior surface, but the anterior surface of the cornea provide a lot of information in our practice to protect our practice for lawsuit, for bad reputation, because we know that any eye surgery provoke the worst dry eye after that. You can see the topography, they check about the curve, elevation map, power, and white-to-white data. And in this one, you can check and compare on both eyes. They have 3mm zone, 5 and 7. We can use the astigmatism data power in 3 and 5 for customize if the patient have the astigmatism significantly or not for premium IOL or advanced intraocular lens choosing. So the next one is keratoconus index, and we can check about the size of the pupil. And the Seneca barometer can check about how tear film affect the optical quality. Because sometimes the vision is good, but the tear film is bad. The quality, the vision is 20/20, but the patient complain a lot. So this one helps to confirm that they have something wrong, except the surgical technique that's good and the lens is good. And lastly, we can compare in each visit, very practical. And this one shows the white to white for contact lens fitting. So pre-operative evaluation for the cataract, irregular the cornea can represent the biometry error. So for the keratoconus screening, if you are the refractive surgeon, you can use this one, and they're gonna have one index we call keratoconus property index. They use, and if the machine show that the percent of the index so increase, they're going to be suspected that the patient may have the keratoconus. So further investigation need to be followed up and sent to maybe PET or another more advanced. And if we suspect, we can use this machine for sequence and serial comparison map. And this is show the graph, show the normal topography. You can see that this whole green. And in the green one, they show that topography not compatible with the keratoconus. And this one, the patient with the keratoconus. So the machine show immediately that they show that the topography compatible with the keratoconus, and the keratometry shows 64 diameter. So the next one is a good one that to use. It's a non-invasive, non-backup time and blink analysis. Before 10 years, 5 years, people don't talk about the blink analysis. But nowadays we know that the blinking mechanism of the eyelid show a lot of the factor to make the dry eye. And this is show the how to measure that this patient have very bad dry eye, and the first treatment time is 2 seconds, and duration of the measurement is 70 seconds. This is show the parietal ring that start to get distorted by the parietal disc. And after blinking, you can see the distortion. And the machine sends the signal to show about the abnormal mapping. If we show the patient face to face in front of the screen, I do believe that the patient will have a good experience. Sometimes with the verbal explanation, it's not that so enough for to make the impact for the patient. If the tear backup time less than 10 is positive for the dry eye problem. And this is a blink analysis. The blink frequency and the completeness of the blinking have been recorded. The term interblink interval and calculate about the ocular protection index. This is analyzed and initiated by the machine, and they're gonna identify the incomplete blinking pattern, and the blinking dysfunction can make and show the patient, oh, this is a one factor that make you feel dry eye. And this is a software that show an average interblinking interval is a 1.18 seconds, and the duration is 25 and duration is 30 seconds. So the patient have really sensitive to the wind sunlight and blink a lot when exposed to the machine. And use the two group of the data in the blue circle and create the ocular protection index. The ocular protection index is a brand new factor that they use a ratio of the non-invasive tear backup time to the interblink interval. If the ratio less than 1, that represents that the patient not blink frequently enough to protect their tear film. This is a key factor. Sometimes we examine the patient and everything is normal, that the patient complain a lot. If we can have this one show the patient, they're gonna make the answer, good answer for the patient. So the next one is the TMS's cut height. This machine gonna show about the aqueous tear volume deficiency. Why this matter? because of the tear meniscus height. If the tear meniscus height less than 0.2 millimeter, that's going to be associated with the aqueous tear deficiency. In the old days, 20 years ago, we put the whole group of the dry eye to be the aqueous tear deficiency. But this is a good clue to separate from the aqueous tear deficiency and the lipid layer deficiency. So for the surgeon, the screening for this one identify the risk, and we can warn and inform the patient that you're gonna have the dry eye after the surgery. If we won't inform the patient, sometimes when the surgical come out is good, they're gonna blame us or as a complication. And the machine gonna have the mode we call enhancement knob. We put the knob and have an enhancement and use 5 spots of the manual evaluation. Some brand of the machine use the AI or the computer. I have used some company that use the AI for calculation about the tear meniscus height. I found that they have some error. If we use our manual super precise measurement 5 spot and put 5 one and we calculate each spot of the 5. And when we click the knob show profile, they're gonna calculate the average. In this case, when I finish the 5 spot of the calculation, I just put 1 second for the knob of the show profile. As you show, they're gonna show that this case have average about 0.34 millimeter of the meniscus height. Below 0.2, it's gonna be significant for the dry eye. This is provide a very good information. This is a case that one side is very bad, really dry in one side and not super dry in one side. Sometimes when we examine the patient with dry eye, sometimes the patient says, oh, my right eye is bad, worse than left eye. If we can show them this information, wow, the patient is gonna say, wow, I haven't seen any eye doctor tell me something like this before. They're gonna make your practice more premium. The next one, this is a cool one. We call lipid layer assessment. The system uses the Guion scale grading. This one is the international system that classification about the lipid layer. But you need to know and read about the classification, and they have the 5 grade from the 1 to 5 color fringes, amorphous, wave, and closed meshwork and open meshwork. Each type show from the good to the bad tear film of the lipid layer. And when we take the photo and the video of the lipid layer, they have the reference in the system of the machine. We can put one knob on the skin and show the reference. So our technician, our young ophthalmologist can clarify the staging of the dry eye for us and document in the software. So we can make it like a report in 1 second. So in this case, we found that in this case they have about get mild to moderate. So when we discover this one, we record it. So this is a cool one. And each type of the grading, they represent the thickness from 80 micron, 50 to 80, grade 2, grade 3 wave, 30 to 50. 4 is 20 to 30, and 5 is less than 20 micron. So the lipid layer, this is a video show the lipid layer, and we can use both video and still picture and for the clarification. The next one, many of us that have the micrography unit or infrared camera in your slit lamp, but some did not have. So if you have the patient and without the micrography, it's going to be very, very difficult to discuss with the patient why you have so bad dry eye, why you have a treat and no improvement. This machine allow you to use a manual label. This is, I think, is provide us for more precise about the location of the whole tarsal plate and the available the residual tarsal plate right now. So if we found this one when we was young, That's why I'm going to say that the Meibomian Gland dysfunction is anti-aging. If you have the young kid with the dry eye really bad, and we treat them in the early stage, we can protect the further damage in long term. And the images show not only the amount of the gland, they show the shortening, tortuosity, distortion, and dropout. And we can label, and you can see after we label the area, on the area of the gland lodge show 39.5%. That's very informative and very documented. So the next one, Meibomian Gland imaging and analysis. They have the 5 scale for this one. And we can use the machine to scale about the severity of the gland also. And the picture of the images is comparing to the DC4 is more wider and more sharper and more easier. And the depth of field of the image is so good. Even though if you have less experience and you use a simple slit lamp with the micrography unit to take a picture, sometimes you're not gonna get a good picture. But this one, very easy, in 3 seconds, you can get a good image of the micrography and show the dropout. Next one, the ocular redness and refractive assessment. This is a good one to show the patient. In the old day, I take the picture every case, like 10 minutes, 5 minutes, and then explain another 10 minutes, 20 minutes. That's consume a lot of time and a lot of fatigue. So if we send the patient to take a picture in the investigation room, after that the patient come and we see in the screen and show them how redneck it is. So cut off the time of the fatigue of the surgeon. So this is more practical and more easy, and we can label and show them. I think the examination is an experience, and the experience is so precious for the patient. And beyond the congenital staining, we still have the limbal redness staining as in the video. We can document in both ways. And the next one, the refractive assessment. You see within 2 seconds, when the patient look down and take the images, we can see the cylindrical dandruff. And if you know and familiar about the demodex, this one in one eyelash, I think they have about 8 or 10 body of the demodex, including the dirty toxic free fatty acid, including of the bacteria inside. But we put this one for culture, it's going to show up a lot of bacteria. But most of us in the old day did not recognize the anterior refractive so much. And maybe from the surgery, cataract surgery, refractive surgery, lid surgery, without eradicate the whole bacteria and demodex. So that's why the patient have the endophthalmitis, dry eyes, super bad after our own surgery. So the next one is fluorescein imaging, the corneal staining, conjunctival staining. We have no need to do take a lot of time again. We just let the technician put drops and then take the picture. I'm going to show, this is the lady, 26 years old. She put the contact lens and a very bad dry eye and the eye redness all the time. You can see the quality of the images is so good to see the bulbar conjunctival staining. And in the system of the machine, they have the grading we call the Chinese conjunctival staining. If you read about the paper, this one is a Japanese system that integrate and available for the interpreter to compare and document how many % of the conjunctival staining. For the corneal staining, this one is a patient that have been treated with the IPL for the previous dry eye, especially for 10 times, but no improvement. They came to me and I showed them that you still have even though you got the enough 10 times of the IPL treatment, but the treatment you still have the staining. because the patients still use computer 8 hours a day. So we need to document how many percent of the cornea that have this one. For document, why it is so important, I always tell, oh, you have 25% at this visit. Next visit, I ask you have 3 or 5% or 0%. This is very important for us to follow up if we want to clarify the improvement in super detail about the percent of the ocular surface information. I think this one is so important for us for give the information to titrate the dosage of the topical eye drop that we use. So by summary, how the TERA maps to the view 3. The step 1, symptom screening, they have integrated the OSDI-6 questionnaire in the machine. We can tick in this one. Step 2, we confirm the eye diagnosis by a non-invasive backup time, hyperosmolality or corneal staining. But the TERA provides the TMNH type and non-invasive backup time and fluorescein staining. And step 3, we clarify this one is lighting deficiency, a deficiency, or a problem, or primary ocular surface disease. So for the whole information, lead us to provide the further treatment. Wow, the further treatment is very difficult for the treatment of the dry eye. I think the treatment for the chronic or serious dry eye is difficult than my eyelid surgery, difficult than my orbital decompression, difficult than the cataract surgery, because we do the cataract in 5, 10, 15 minutes. But the dry eye, MGD, we have to treat them for the rest of their life. And sometimes we need to talk for hours and let them understand how the root cause of the problem and how if you less about the issue of the demodate, you need another 15 minutes. If you less about Meibomian Glands, you need another 15 minutes at least. That's the problem. So by another conclusion, the machine is good for because it's a one-touch auto alignment, and they have the standard system that integrate in the software, and they have the TERA review software. If you have 5, 10 examination room, or you can review at home or integrate and send the report from home. And comprehensive dry eye unit, if you're gonna set up the super dry eye center, this is a good tool and good toy for you to learn and use it. And reflection, the true images. Experience for the patient is so important. Don't let the patient say, wow, why if we check with you and check with another ophthalmologist, why Dr. Nattawut did not tell me about this? That's gonna make me feel embarrassed. So it's flexible and convenient to any practice. This is a machine on the left upper, and this is a software we call TERA Viewer. And on the lower left-hand side is one click. It's going to show the PDF file or JPEG file, or sent by the another handy drive or another PC for the report. So you can see that the 10 minutes that we do the examination, we have plenty of the report that can show the report. It will show the summary of the dry eye problem, keratometry report, comparative visit, and TERA review software. This is show the whole investigation that was done in only 10 minutes. By summation, the TERA system compared to the slit lamp alone and the traditional dry eye analyzer. They provide the non-invasive backup time, extended wide field meibomography, good quality, corneal topography with the parasitic ring, and keratoconus staining very quick, and the standard grading for system, and the due to report immediately, and remote software and pupillometry. So this is quite pretty new because the machine just launched in Asia Pacific, and the show in February in Hong Kong of the Asia Pacific conference. And the Topcon told me that this is just only the first official event that talk in deep about the TERA. So hopefully the company can develop better, more software and more precise software. Example like the AI that super precise, and I think they have a good future for the machine, and so fun to use the machine. So by summation, the right tool for the right patient make your practice is so premium. Thank you very much.